Hi, everyone. So today's topic is surviving survivorship and gynecologic cancer with Dr. Patricia Ganz. Dr. Patricia Ganz is a medical oncologist at UCLA and is a pioneer in the assessment of quality of life in cancer patients and survivorship care. She brought her trademark insight and warmth to the 2025 Women's Cancer Survivors Conference. In her thoughtful review presentation, she reflected on how far we've come in understanding the long-term needs of cancer survivors, especially women, and reminded us why survivorship care is just as essential as treatment. With decades of research and advocacy under her belt, Dr. Gans made it clear survivorship is a journey, not just an outcome. In this session, you'll learn from Dr. Gans and leave with concrete information about survivorship as she reviews highlights from the 2025 Women's Cancer Survivors Conference. So thank you again so much for having us, and the floor is yours.
Thanks. It's my pleasure. So let me just share my slides. Okay. Are you able to see it?
Yes.
Okay, great. Okay. So I'm going to be talking about survivorship in general so that we have kind of a background of the rising numbers of survivors who really are an important product, if you will, of the success of cancer treatment over the last several decades. But I'm going to be focusing on fatigue and cognitive changes after cancer treatment because these are very common during treatment, but in many survivors, they persist. And I've been really studying these for the last 25 years. So I want to share that information with you. And I'll be happy to take questions at the end of this. So just if you jot down anything, we can go over it at the end of the presentation. So just a few disclosures. So why is it important to even think about studying symptoms in cancer survivors? Well, first of all, there are more than 40 million cancer survivors worldwide. So again, a huge number of people, larger than many countries in size. And in the US, over 5% of the population is cancer survivors. And that, as I'll show you, is about 18 million people, which again, I live in a large city, you live in a large city, that's more than the populations of our cities. So it's a huge number of people. And the other thing to note is that more than 70% of cancer patients who we treat today will be long-term survivors, although we consider everyone a survivor from the time of diagnosis, because we actually have to think about, as we treat people, what could be the sequelae of our treatments and how it could affect them as survivors. But we have so many people now who are actually living with active metastatic cancer and having the disease controlled, that's another growing population of people. So it's important to realize this is a very kind of all-encompassing group in the population of people who've been diagnosed with cancer. And we're expecting the number of cancer survivors to increase very sharply over the next decades because of the aging of the population. And a few years ago, there was a statistic that every day 10,000 people were turning 65. It may even be larger now. So it's a large number of people who every day are getting into the age group where they've lived a long time and the risks of cancer increase. And this again kind of shows you what's happened over time. As you can see, in 2022, this estimate was 18.1 million individuals. By 2030, it's 21.6, and then at 2040, 26 million. When I was involved in a pretty pivotal report from the Institute of Medicine in 2006, we only had 10 million survivors. So you can see how this has gone up. And the color codes here on this particular figure really show you the duration of the survivorship. But if you look at the brown widening band here, these are people who are living after a cancer diagnosis more than 25 years. And of course, green 5 to 10 years and 10 to 15 years. So not only do we have an increase in the number of people who are surviving a cancer diagnosis, but the length of time that they're living after their cancer is growing as well. And this is again showing you, just looking at the distribution in the population. On the left are women and on the right are men. And what you can see is in the lighter blue bars, what the estimate is today of the number of people in each age group who are cancer survivors. So if we look at 85 and older, over 35% of women are cancer survivors in that age group. And similarly in men, we've got about 47%. And we see this is going to grow in this aging group, but again, looking across the spectrum.
Magic Johnson announced he would donate his $3 billion estate.
Okay. And here again, in younger ages, we also see large numbers of individuals who have a history of a cancer diagnosis. So how did we make such incredible strides? Well, earlier detection of cancer, we have a lot of screening that we can do that is effective. Detection of cancer, new drugs and other treatments, combining various treatments. Again, when I was a young oncologist, people might have just had surgery or they might have had just chemotherapy. Now, most people are going to be getting a combination of at least 2 or 3 different kinds of treatments. We have new treatments like immunotherapy, we have targeted therapies. And so that has really made a big difference in the survival rates and people living either off of therapy for long periods of time or some people on therapy. And then adjuvant therapy, that's treatment that we give around the time of the diagnosis to prevent a recurrence. That was something that didn't exist in the 20th century or started to develop in the 20th century. And now many people are getting treatments that are afterwards. So in the case of breast cancer, women may be on endocrine therapy for 5 or 10 years afterwards. And so again, the strategies have changed that's led to this improvement in survival. And then we're doing a better job of preventing second malignancies when we give women with breast cancer endocrine therapy to prevent a recurrence of the first cancer. We're actually reducing their risk of getting a second cancer in the breast. So that's very important. And there are other prevention strategies, certainly knowing the genetic risk of cancers in case of breast and ovarian cancer, the BRCA1 and 2 genes, other genes that are associated with ovarian cancer and endometrial cancer can be very important in risk reduction and preventing additional malignancies or first malignancies. So that's been really important. But, there is a cost. There's a very important human cost, and that includes the time of getting your treatments and all the follow-up, the costs, which are huge, and the financial burden is a big issue today, and the other human, interpersonal, and existential issues that arise facing a very serious life-threatening disease like cancer. But for many patients, cancer is now a chronic disease. It isn't just over when that first treatment ends. And it's also chronic in terms of the persistence of post-treatment sequelae or side effects from that treatment. And so that's what we're going to be talking about with some of the symptoms I'm going to be discussing in more detail. So let me just give you a couple of definitions, not something that you have to memorize or even really think about a lot, but we think about these kinds of side effects of cancer treatment as either being a potential long-term effect, which means something that actually starts during your treatment and then never really goes away. And fatigue, cognitive complaints, and pain are 3 examples of things that often come up during the treatment. We can even think about neuropathy from taxanes, which some of you are platinum, which you may be experiencing. It comes up during the treatment. We hope it's going to go away, but it doesn't always end and it persists. So that's a long-term effect. A late effect, which is sometimes more infrequent, is a symptom or a problem that comes up months to years later, such as a second cancer, developing heart failure, developing swelling that we call lymphedema. Those things can just come out of the blue, 3, 4, 5 years later. And it is, in fact, a consequence of the initial treatment, but is only coming to be evident at that point in time. But some things can actually be either long-term or late effects. You may not have any pain initially, but it comes back later. So again, not important to really label things one or the other, but just to realize that there are things that may occur as a result of that primary treatment that will be ongoing in the survivorship period. This was a recent publication where the authors looked at a survey, which is called the National Health Interview Survey, which is given to a random sample of the US population. It's administered every year. And what they did was looking at cancer patients who had answered the questionnaires and healthy people who had not had a cancer diagnosis. And this is looking at the individuals who are cancer survivors in the sample who were endorsing a question that they had limitations in their function in everyday life. And this is back 1999, and you can see in 2017, there's an increasing number of survivors in this sample who are reporting that they have some limitations as a result of their cancer treatments or in association with their cancer diagnosis. Here's the general population. There's a little bit of increase, but much greater in people who have had a cancer diagnosis. Similarly, this is the rate, if you will, of increase. And again, here we see in 2017, there's a 2.25 fold increase in the number of individuals endorsing limitation who have a cancer history, with only 1.34 in the those without a cancer diagnosis. So yes, the people in the survey have increasing limitations, but it's much more pronounced in the cancer population. And here are some reasons why. I'm going to start to get into some of the biology of this. When people get treatment for cancer, really almost any kind of treatment that we do, whether it's surgery, radiation, chemotherapy, targeted therapy, the normal tissues are what we would call innocent bystanders. While we're targeting the cancer, and some of our treatments are much more focused on the cancer itself, the radiation and chemotherapy can have off-target effects on normal healthy tissues. And things that also contribute are characteristics of the individual, the biology of the person, and how resilient their body might be in terms of the effects of the cancer treatment. And so up here in this diagram at the top here, you can see all these different kinds of therapy, and we're going to want to wipe out the cancer cells with our treatment, and we hope that the tumor is going to shrink and come under control. But then we also have these normal cells on the right who are also being injured. And what we know is that some of these cells actually die and become what we call senescent. They kind of go to sleep and they're not active anymore. And as a result of this dying process, they begin to produce increased inflammation, and that inflammation actually affects the heart, the brain, the bones, muscles, and can accelerate what we call an aging process. And of course, we all know, if you know anyone who's lived into their 80s or 90s for sure, they often become less physically active, they have more fatigue, they may sleep more, they may have some cognitive changes. And this is something that we expect in somebody in their 70s, 80s, or 90s for sure. But sometimes in people who've been treated for cancer, we begin to see some of these symptoms of accelerated aging, called frailty, occur 10 or 15 years after the cancer treatment. And if you're 50 years old and you got treated for cancer, and now at 60, you're impaired in terms of your physical activity, that's an early onset effect and a toxicity of the cancer treatment. So more and more, we're looking at survivors and trying to understand why some individuals will have this accelerated aging and others don't. And it probably relates to individual characteristics that allow them to be more resilient, just as we see huge variability as people age. People, as we know, many like myself are working way into their late 70s, and other people may be retiring at 60. So what are some of the chronic symptoms that we see in adult cancer survivors? Well, fatigue is common, and about 25% of individuals will report persisting fatigue after their initial cancer treatment. And in general, it's related to the intensity of the cancer treatment. So if you get radiation, chemotherapy, surgery, targeted therapy, immunotherapy, or a transplant of some sort, high dose chemotherapy or CAR T now, things like that, you're much more likely to have fatigue than if you just have a little simple excision of a skin cancer or a breast tumor. Cognitive difficulties are also common, and it really depends again on the kinds of treatment. Neuropathy, which again is associated with several kinds of chemotherapy treatments and other therapies, some of the myeloma therapies also. Pain, decreased physical functioning, and insomnia. So these are all very common symptoms. They're common in the general population, but we're talking about an exacerbation or a worsening of things that we might see in the background for people as they age in people who've had cancer treatments. And many of these are conditions that are common in aging and associated with that frailty phenotype that I was describing just a slide ago. So these are a couple of my colleagues, Dr. Bauer and Dr. Irwin. So I'm a medical oncologist, but I've been very lucky to have collaborators who know a lot more than I do about the neuroendocrine and immune mechanisms of behavioral comorbidities in patients with cancer. And this is a paper that they wrote. This is way back, I think in 2006 or 7, where they and other colleagues really described how cancer and its treatment, and you can see that on the left, tumor, metastases, chemotherapy, psychological stress, surgery, and radiation, can have an effect on the brain, the neuroendocrine system in the brain, which then can affect sleep and cause sleep disturbance. And this is all set up by inflammation that's occurring because of the treatments that we are giving. Again, as I said, tissue is injured, we have off-target changes, and we have inflammation. That's very common as part of our acute cancer treatment. But in some people, that inflammation persists after the cancer treatment ends, and we see effects on all of these things, leading to the behavioral alterations that you can see on the right. And depression, fatigue, impaired sleep, and cognitive function are all kind of outcomes my colleagues and I have been studying for the last 25 years. So I'm going to spend talking about fatigue first, and then I'm going to talk about cognitive dysfunction. So this is a quote. See, it's from over 20 years ago. It was written by a physician who had finished breast cancer treatment. And she said, during cancer therapy, I always felt the exhaustion of physical exercise without any of the positive attributes. My limbs felt heavy. The quality of my sleep was changed. The mere act of sleeping itself seemed like work sometimes. My brain felt tired, and so did my spirits. I seem to have lost my zest for life. And so I think this is pretty common of patients who have had complex treatments, talking to them after they finish their treatment. And of course, what we know is it takes many months to even a year or more to get that energy back and feel better for most people. But when it doesn't persist, when it persists, that's when we become more concerned about it. And so I've been talking about inflammation. There's a lot written about this in the lay press about anti-inflammatory diets, things that cause inflammation. But this is in general, the body's response to infection or injury, and it's mediated by these particular proteins, which are pro-inflammatory cytokines. You don't have to remember them, but I've just listed a few of them here. And they have both local effects. So if you get radiated, you may get redness in the skin in the area of radiation, but there's systemic changes that are part of the inflammation and can also affect the brain and the nervous system. This is another cartoon that kind of shows this in a little bit more graphic form. You know, again, if you have an infection or a wound of any type, there can be local inflammation, and your body responds to this with an inflammatory response, and you can see them listed here, some of these cytokines, and then they go up to the brain and they have an effect on the brain, and they can then cause a decrease in appetite, energy, social activity. And when we see this in animals, we call it sickness behavior, because if an animal is inflamed and has an infection, or we give them something causing an inflammation, they'll just, the mouse will just curl up in a little ball, doesn't want to socialize. It's in the cage and really is responding. And of course, if any of us gets a bad flu or serious, we feel the same way. But this is a side effect of cancer treatment. And in some people, this inflammation just doesn't subside or come down after they finish their cancer treatment. So what are some of the things that we found, and this is primarily in breast cancer patients, but I think in other patient populations, we've seen this as well. There are things that may make some individuals more susceptible, and having underlying cardiovascular disease, an elevated body mass index, or being obese, biological factors such as anemia, which again, during treatment may be a factor, but is seldom a factor ongoing. We see more risk for fatigue in younger individuals than older individuals, people whose income is lower and people who are unpartnered. And people who have a history of depression may, again, have a higher risk of fatigue, but most of the time when we see fatigue, people are not depressed. And people who are catastrophizing, which means they're worried about a lot of things as a coping style, may be more at risk. People who are physically active are at less risk of having fatigue after treatment. And we know that this is actually an active intervention that we offer to people who have fatigue. And then other things that may co-occur with the fatigue are pain, menopausal symptoms, hot flashes, difficulty sleeping, and sleep disturbance. So all of these are associated with fatigue. They're not always there, but they may be part of that syndrome. And as I've already talked to you about, inflammation that persists after the cancer treatment is something that may be making it continue even though the treatment has ended. So what's driving this inflammation in the long-term survivors? Well, again, what we've seen are alterations in how the body responds. And the body has a fight and flight mechanism where we have an increase in steroids in our own body that then suppress inflammation. And what we found is in fatigue breast cancer survivors, they do not mount that response. And so I'm just going to show you an experiment that we did. These were breast cancer survivors who were about 7 years out after their breast cancer diagnosis, and half of them had fatigue persisting all that time, and the other half after the treatment had normal energy. And we brought them into the research setting.
Infinity calling.
where
We
we-
must hear from you today. The fifth
Okay, so we brought them into a research setting where they were in front of a group of judges who wore white coats and were asking them to give a speech as well as doing arithmetic calculations and really kind of egging them on and saying, you're not doing this fast enough, please give me a response. This is a standardized psychological stress test. And so it's known to promote stress in most individuals. And what did we do? Well, before they did this test, they had blood drawn and saliva collected, and then we collected it for the duration of the saliva, for the duration of the speech, and then afterwards to look and see whether they had an appropriate response to this stressful experience. And what you can see here, dark circles, are the women who didn't have a history of persistent fatigue, and they had a nice bump in their cortisol from this stressful experience. Here is what we would expect, but we see a blunted response in these women who 7 years after their cancer treatment were still experience fatigue. And just to kind of summarize how this might reflect everyday life, we have everyday life and hassles, and if you can't mount that response, you may not be able to suppress the inflammation, which I'm going to show you here. In the non-fatigued women at baseline, these were the levels of the inflammation that they had. And as the cortisol went up, the inflammation went down. But look at the women who were fatigued. They, during the stress, actually had a rise in inflammation. And we said earlier that the inflammation is associated with increased fatigue. So the stressful experience did not allow them to suppress that. And as a result, they were more fatigued as a result of that. And this is just more data showing the correlation. So this is a long-lasting effect after cancer treatment. We were also interested in looking at whether there were effects on both cognition and mind and body after cancer treatment, as well as inflammation. And so I did a study where we recruited about 200 women to be enrolled for follow-up after they finished their chemotherapy, radiation, surgery, but before starting endocrine therapy. And then we followed them out over the course of a year. And I'm going to show you what we found for them in terms of the severity of the fatigue. We found there was an association between genes in their blood, their DNA. So this is kind of the characteristics of the individual that were associated whether they had higher levels of fatigue. And these are genetic changes in the genes that are associated with those inflammatory markers that I showed you. So individuals with this particular distribution of this particular genetic element had higher levels of fatigue compared to this group. Same thing here for this group of individuals. They had higher levels of fatigue and here. And so depending on how these individual women were genetically existing, they might have had a higher response to fatigue. And these genetic elements in the gene may be controlling the inflammation that they experience. And what you see here is somebody had all 6 of these high-risk alleles, they would be more likely to have greater fatigue. And what we found was, in terms of predicting fatigue, age, so younger age was a predictor, being obese was a predictor, race, ethnicity didn't have a role, having had chemotherapy did, that was a higher risk, and then also this genetic risk score. So some individuals are more predisposed to have persistent fatigue after treatment just because of who they are. Those are those host factors. And we also found that this was associated with increased cognitive changes. In all of the research we've done, we found that fatigue and cognition problems are closely related. This is just to show you how this particular inflammatory marker, TNF receptor 2, changed over a year. This is at the end of primary treatment for breast cancer. And you can see the women who had chemotherapy had higher levels of this inflammatory marker than the women who had not had chemotherapy. And it slowly declines over the year. So it's still different 6 months later. And at a year, they're similar. These are not statistically different, but there are some women who are still having persistent inflammation, even though they're a year after their cancer treatment ended. And some of them were on endocrine therapy, some were not. And this is again showing how this particularly relates also to cognitive changes, which is what we were studying in this particular study. And just to show you, using PET scans and visualizing this, this is a woman who had a low level of TNF receptor 2 at the end of her treatment. And she has very good activity here in the front part of the brain, which a year later on a scan was also normal. But here in this particular individual with a high level of TNF receptors, there's less activity. This is metabolic activity in the front part of her brain, which gets better a year later when the levels fall. So just to kind of show you how this inflammation does affect the brain. So another question is, is everyone going to experience fatigue after treatment? And this is a study looking at women before they started their breast cancer treatment. So this is where the baseline is. And this particular fatigue scale, these are normal low scores here. This is a little bit elevated. These women have very elevated scores even before they start their breast cancer treatment. And what you see is there's a large group here, which I'm going to indicate here in green, a large number of 178 women out of about 270 in this particular study who really didn't have any fatigue during their cancer treatment, and a year and a half after the end of treatment, they didn't have any fatigue at all. But look, here's a group of women in purple or lavender here, where it's increasing over time, and this group has a decline, and this group is high and stays high. So if you just looked at women who were a year and a half after the end of their treatment, you would have a large number of women here who don't have fatigue, but we have some with elevated fatigue, but some of them had it right from the get-go. It didn't really change, and others had it increase. So when we look at long-term survivors, the patterns by which they get to having persistent fatigue vary. So this is, again, just a cartoon to really show you what's happening. We have individuals who are going to be getting cancer treatment down here, and these white cells are going to be making products, which we call cytokines, the inflammatory markers, that can travel up to the brain and have an effect on the brain that then affects how people feel and can affect how they're functioning in terms of fatigue and cognitive function. But things that may make some individuals more susceptible are pre-existing things that actually don't necessarily have any relationship to the treatment, but who they are, like those SNPs, those genetic abnormalities that I showed you that may make some people more susceptible. So this is why, some clinicians over the years have said, oh, I've never seen anybody with fatigue, or I've never seen anybody with cognitive changes. I've treated hundreds of patients and nobody has it. Well, first of all, either the patients weren't brave enough to complain or they didn't ask about it. But in fact, a large number of people will do just fine. But those who don't, we have to believe them because this is a biological problem, okay? It is not psychosomatic. Okay, so that's, I think, if you take anything from my talk here, these are real, they're biological phenomena. So how do we treat fatigue? I'm going to just see how I'm doing with time here. So things that we can do include yoga, which is, again, a form of physical activity, but has kind of a mindfulness component to it. But other kinds of exercise, stress management and relaxation are all helpful. And many of these are very adaptable for fatigue patients who may not be out and able to do standardized exercise programs. And just to show you a study that Dr. Bauer did and led in women with very severe fatigue after breast cancer, they had 12 weeks of 2 90-minute sessions of Iyengar yoga every week. And we looked at fatigue before and afterwards. And again, I'll show you a picture of how the women are kind of posed and positioned. And then we compared this to just a group of women who got survivor education that met every week for 2 hours and had presentations about things related to cancer. And this is just to show you how they were posed for the yoga and in positions. But just to show you what happened was that those who were in either group, had the same fatigue severity at the beginning of the intervention. But then over time, we see no decline in fatigue severity in the education group, but this dramatic and significant decline in the women who were in the yoga group. And in terms of vigor, an increase in vigor in those. And these were all statistically significant. Interestingly, both groups had an improvement depression, but fatigue did not change in the group that had education alone. And so these are just some data to show you that we actually were able to measure differences in inflammation and showed an improvement and reduction in inflammation with the yoga. So again, showing that these activities can in fact cause biological changes. And what happens is that we've been, as a community of people interested in post-treatment survivorship concerns, have now had 2 guidelines on the management of fatigue in adult survivors of cancer. And this was one that was just updated last year, where you can see there are recommendations for exercise, cognitive behavioral therapy, mindfulness-based programs, Tai Chi or Qigong. Again, during cancer treatment, this can be helpful. And many of these are also evidence-based and shown to be valuable after treatment. And again, there are a few other acupressure, yoga, and moxibustion were found to also be possibilities. So there's no reason not to try something if you're having fatigue after cancer treatment, because there's good data to support these as being beneficial for patients. So now going back to that framework here, I'm going to talk about cognitive dysfunction. And again, this is something that patients frequently will complain about, but doctors don't necessarily pay too much attention to it unless they're really, really impaired, but it's a common problem. And again, you can see in some studies, as many as 75% of breast cancer survivors show deficits after a cancer treatment immediately, but then also many years thereafter. And as with fatigue, we've got a subgroup of patients who really don't get better after their cancer treatment ends. They're still having troubles with cognition a year or 2 later. And so when I see patients, really, I kind of ask, when did your problem start? And, has it gotten any better? And for people who are not having improvement, we're really concerned about the long-term changes. So again, it's not just chemotherapy. Initially, this had the name chemofog, but really almost any cancer treatment can do this. And some of the people who have been studied before they even start their cancer treatments with a variety of cancers have deficits before treatment. So it's possible that the cancer itself may be causing some cognitive changes in people, which don't necessarily improve after the cancer treatment. So what do the survivors complain of? I'm still able to function. It's just the fine degree of memory or speed of processing, which may be very difficult. I am spent. They describe a mental fatigue, which is, again, they just have to work harder to get an answer or find a name. And I'm just not as sharp as I was. So again, these are somewhat subtle complaints. I have seen people who are very impaired, but more often it's a more subtle complaint syndrome. And again, if somebody's working and managing their children and a whole bunch of other things and multitasking, they may be much more aware of this than somebody who may be retired and may not have as much going on in their lives and may be able to pace themselves a little bit better. Because when I started to study this, I would ask every patient I gave chemotherapy to, how are you doing? What's happening? And in general, my older patients didn't have as many complaints as my younger patients. So here's just a way of kind of looking at all the things that can potentially cause changes in the brain. Most of the drugs that we give as cancer treatments don't get into the brain. There's something called the blood-brain barrier, but other drugs do. But it can also happen that the chemotherapy or radiation doesn't cause direct injury to the brain, but there can be this inflammation associated with the treatment, which then causes damage in the brain. There can be genetic susceptibility. There's people who are more potentially at risk for ApoE4 type Alzheimer's may have a slightly increased risk. We just don't know. I mean, again, this is the issue of the characteristics of the person in whom the cancer occurs. And then the hormones like estrogen or testosterone, where men may have testosterone therapies as part of their prostate cancer treatment. These hormones are also very important in terms of affecting the brain. So it's really the things that can cause cognitive complaints are multifactorial. If somebody is depressed, they're not going to be thinking as clearly. They may have the genetic factors, the hormone changes, and chemotherapy direct effects. If you get radiated to the brain, this can cause injury directly. And again, in my experience, high functioning individuals may be more likely to notice even very subtle changes. And so, how did we first find out this was a problem? It was actually breast cancer patients who were being treated with high dose chemotherapy and higher dose adjuvant therapy that more than we give today, really led to this naming of this as chemo brain or chemo fog. But as I've mentioned, we have kind of moved away from this and really talk about cancer-related cognitive impairment today. And so what's happening is the brain is having changes over our lifetime in terms of our ability to adapt to things. And again, we may have a shift to a lower kind of curve if someone's a cancer survivor, but there may be some as cancer survivors who have this accelerated trajectory of decline in function. And high cognitive reserve, people who have high education may have a slower decline than people who may have a lower cognitive reserve. So these individual characteristics may be part of what's explaining some of the variation. Just again to show you over our lifetime, everybody is having a decline in their speed of processing and their memory. This is just universal. But some of these things are maintained, our word knowledge and so forth is often maintained. But many of the things that we see in cancer-related cognitive impairment are the kind of things that we would see with aging. So it's not an Alzheimer's type experience, a dementia experience. It's usually slowing of speed of processing, word recall, things like that. So many patients will worry that they're going to have dementia after cancer treatment. That's not the case. And again, inflammation is also associated with various aspects of the brain, its characteristics, the white matter, which again is something that we see in aging in general. And this has been noted in breast cancer survivors after chemotherapy treatment. And what happens is that during a memory task, older individuals need to recruit more of their brain to answer a question. They may get completely the right answer, but they're working harder. And whereas maybe one part of the brain would normally be helping in responding, in an older individual, more parts of the brain are activated. And that's what we see in cancer survivors. And that's why we think about this as an accelerated aging process. And this is a really cool example of an identical twin who had breast cancer, and she had had chemotherapy treatment as well as tamoxifen. And this is her identical twin that is in this particular picture here, and no chemotherapy or any other exposure. And what they were asked to do while they were in a functional MRI scanner was to do a task where they had to remember something. And what we see is at the beginning of the task, the memory task, by the way, both of them, both the woman who had had chemotherapy and her sister, both had normal performance. They answered the questions correctly. But to get the right answer correctly on the first part of the test, you can see this woman was activating this whole frontal part of her brain, where her sister just had a little activity. Then in the next part of the test, even more of the brain was activated, and then here even more. So the sister without cancer treatment is activating her brain as the test is becoming more stressful, and is using all parts of her brain, but much more needs to be used in the person who's had cancer treatment. So it's a very nice visual of what's going on. And this is a study that we did in longer term survivors, where we looked at during a PET scan, women had to do a task in that scan. And we see that the women who had not had chemotherapy had much less activation of the brain in this frontal area than the patient who had chemotherapy. So again, there's a compensatory response, working harder. And that's why patients will describe it as mental fatigue if they have to actually work harder to get an answer or work on something. So it takes more energy and there's inefficiency, but they actually may have the correct answer on something. And this is really consistent with mental fatigue that patients report as part of cancer-related cognitive impairment. So some impacts on this, again, hormones may also play a role in this, and there may be an issue in women who have gynecological cancers who may lose their ovarian function, or women with breast cancer who may be treated and lose their ovarian function because of the chemotherapy, or possibly because of ovarian suppression therapy. So this may also make women have more difficulties word finding and other kinds of mental tasks. And tamoxifen is one of the drugs that we commonly use. And this may also have an impact on cognition, as well as lowering of the hormone levels with the aromatase inhibitors. So again, just to kind of picture this, if you have somebody who's normally going to be on a gradual decline, as I've shown you, over time, there's not going to be a big change with the treatments. But if she has an induction of menopause abruptly with cancer treatment, then she may get to this point much more quickly. And if a woman who's postmenopausal, the kind of time of treatment, she may just have a gradual decline over time. So these kind of treatments and removing the ovaries and the source of estrogen in premenopausal women may be a complication leading to cognitive changes. And this is again from a study that was done a number of years ago, where women were randomly assigned to either get endocrine therapy alone or chemo and endocrine therapy as part of this trial. And what they showed was there was a bigger decline in cognitive function if women had both of the treatments for breast cancer. But if we look at the premenopausal women, there's a big decline acutely with chemotherapy, probably shutting down ovarian function, and then it kind of comes back up and is not much different than endocrine therapy alone. But in the postmenopausal women, there really is a significant change when there's chemotherapy given with endocrine therapy that persists over time. So there may be a combined effect of the two. So it's, again, all the kinds of treatments that we give to patients may have variable effects on brain function. So what can we do with cognitive changes? Well, again, we need to address any other correlated things such as depression, pain, anxiety, because if one is feeling stressed and having depression or anxiety, that may make it difficult to function mentally. We have to make sure that people are sleeping properly. We want to manage fatigue. And if the complaints persist, with doing all of these things, then a neuropsychologist who's a trained person who can do testing for neuropsychological functioning can really sort out whether there's an impairment that's serious and maybe slightly a reduction from what we would expect as normal, or identify things that might be helpful in terms of interventions for rehabilitation. And again, we don't really have any drugs right now that are good at treating this. So in pediatric cancer survivors where cognitive changes are pretty common and they have learning problems, cognitive rehabilitation has been used. We're testing right now computerized training in a big trial with breast cancer patients to see if that might help with improving cognitive changes, and cognitive behavioral therapy, memory training, and speed of processing training are all things that are in use. People are also looking at anti-inflammatory agents, since we know that inflammation seems to be associated with this. There's a lot that we know about exercise, particularly in aging people and cognitive changes, which seems to be useful. And again, this again needs to be tested in cancer patients and cognitive rehabilitation strategies. So I'm just going to try and sum up some things here as I'm getting close to the end of the talk, is just to kind of show you that this accelerated aging framework, which I presented earlier, is one that can kind of put this together in terms of identifying people who may have risk for some of these post-treatment symptoms, people who've had pre-existing problems, some kinds of lifestyle factors that may predispose them to having inflammation occur in excess as part of their cancer treatment, may be left with increases in inflammation after treatment that affect their physical functioning and their brain functioning, and then cause some of the symptoms that I've described in more detail. This is kind of looking at the cellular level. And the tissue inflammation, again, is kind of an off-target effect of the cancer treatment. We're hoping that the drugs are going to only injure the cancer cells, but we know that they do cause inflammation. And so with this inflammation being increased, we can have the symptoms that I've described, but some of these behavioral interventions that I've already told you about may be very helpful in reducing stress, handling sleep, again, improvements in physical activity, decreasing obesity, and improving energy. All of these things, elimination of tobacco and alcohol, they reduce inflammation and reduce this aging phenotype, and then hopefully reduce and improve biological aging that we think is really part of the underpinning of why some individuals have symptoms. So how do we think about cancer survivorship? As I mentioned, everybody we think is a survivor from the time of diagnosis. So we're going to treat people either with intent to cure. Some people with very advanced disease may only receive palliative care, but if anybody's getting treated, they may be going on to live either cancer-free or with chronic disease with cancer, and then again go through this cycle in terms of recurrence of cancer. But how do we deliver care to the people who are survivors of cancer? And this was something that I was talking about for a long time and finally wrote this up in this particular article, but about the 3 Ps of survivorship care, and their palliation, prevention, and health promotion. And palliation, has had kind of a connotation of something you do when somebody is at end of life, which is absolutely incorrect. Palliation really means focusing on symptom controls in individuals. And often this is symptoms where the cancer is completely under control. You've had curative treatment, but you still have persisting pain, fatigue, sleep problems, etc. And so we want to palliate or manage those symptoms in anyone who's had a cancer diagnosis. And that's a very important part of the follow-up of cancer survivors. And other things that we need to focus on are prevention. Again, thinking about that accelerated aging process that I've described described to you. We want to address cardiovascular risk factors, controlling blood pressure, your cholesterol, making sure your weight is under control. And all of these are really important for managing or preventing chronic condition that can be secondary treatment. But even more important is continue to be screened for other cancers. Again, if you're a woman who's had a gynecological cancer, screening for colon cancer and lung cancer, if you've been a smoker, are still really, really important things, certainly breast cancer. So genetic testing again, knowing that you carry one of these genes that may predispose you to another cancer can be very important in terms of prevention. And then health promotion, very, very important. Avoiding tobacco, alcohol, having normal weight, doing physical activity to maintain function, to monitor and maintain your bone health. These are all really important strategies. And for management of some of the post-treatment symptoms that I've talked about, the mind-body techniques are really very helpful. So where does that leave us? We need to do risk assessment and intervention at diagnosis so that we give people therapies that are going to reduce the risk of having complications. We need to have safer therapies. We need to focus on quality of life and good outcomes for patients. And we need to integrate this into survivor healthcare delivery. So just getting back to that quote that I told you about from this woman in 2001, she also said in the article, it is to be hoped that in the near future, these approaches will be complemented by therapies soundly based on our understanding of the pathophysiology of fatigue with proven successful interventions. And I've hopefully telling you today about a lot of things that you can do if you have fatigue or cognitive problems after your cancer treatment. So just again, to thank my collaborators and the funders of my research.